Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today in the Conversation with Cancer Experts series, I have with me one of the thought leaders in myeloma, Dr. Brea Lipe, who's professor of medicine and directs the myeloma program at the University of Rochester in New York. And we're glad to have her today to talk about a topic that is very contemporary, and we just have started having data emerge on sustained MRD negativity. Welcome, Bria.
Thank you so much for having me. It's great to be here.
So, Bria, so I guess we've talked about sustained MRD negativity in myeloma for a while now. To set the stage, what is the definition of staged MRD? What is sustained MRD negativity?
So, that's actually a good question because it's something that has evolved over the years as we've gotten better technology. And so MRD stands for minimal residual disease. And that's basically how deep of a remission someone has achieved. And at the very deepest molecular levels, how much disease is left. So with the MRD testing that we have available now, we can actually detect up for some patients up to a level of 1 in 10 times 1 times 10 to the negative 6 cells are not cancer cells in a bone marrow biopsy. And what we know is it used to be 1 in 100,000, then 1 in a million. So we're just getting better and better at detecting those very low levels of disease. And we find that that correlates with outcome, so that the less myeloma you have, the better you do overall. But now some of the most recent emerging data is not just achieving that MRD negative status, but can you keep that MRD negative status? And that is better able to help us distinguish amongst patients their risk stratification, how best to treat them, and guide them moving forward.
So it seems like at the ASCO meeting, for the first time from large prospective studies, we've started getting some data on what sustained MRD levels we are able to achieve. So it'd be great for you to go over this for our audience. So the first study we're going to talk about is the Perseus study. For those who are not familiar with the study, could you just briefly tell us what this study was doing?
So this was a study for transplant eligible patients, and it randomizes patients to bortezomib, lenalidomide, and dexamethasone, which is sort of our standard triplet therapy, or had been our standard triplet therapy. They were randomized to either that VRD or daratumumab added to the bortezomib, lenalidomide, dexamethasone backbone. So these were importantly, this was for patients who were transplant eligible. They were less than 70 years of age. They got 4 cycles of their induction therapy. And I think some of the nuances here also matter. When the bortezomib was used, it was dosed in days 1, 4, 8, 11. There were pretty high doses of dexamethasone used in this particular trial. But after that induction phase, they got their transplant, the stem cell transplant. They got 2 cycles of consolidation, which looked just like their induction therapy. And then they got maintenance. So for patients on the standard triplet arm, they got lenalidomide maintenance, and patients on the quadruplet arm, they got daratumumab and lenalidomide maintenance for at least 2 years. And then those patients who had sustained MRD negativity were able to stop the daratumumab while continuing the lenalidomide, with ultimately those patients who recurred and had MRD resurgence or lost their MRD status, they were able to go back on the daratumumab. And this was continued until disease progression.
And so, what have been the top line results so far that we have been privy to?
So I think one of the things that we're seeing is that when we're using these very effective therapies and keeping patients on maintenance, is that overall patients are doing really well. So this is median follow-up data after 47 and a half months. So that's about 4 years. And we're finding that patients, the median progression-free survival has not been reached in either arm for these patients after 4 years, which is really impressive survival data and something that we haven't necessarily seen in the past and is kind of changing the way we approach myeloma because we have within trials like this now the ability to understand who these people are and what it looks like when they're achieving these very long responses. And that's where the MRD status comes in. And so this is looking at the overall MRD negativity rates. And so this here is data at 10 to the minus 5 and 10 to the minus 6. So very deep molecular remissions that we're finding here. And we can see that with the quad induction and the maintenance on the quad arm, these patients are achieving these very high MRD negative rates. 75% of patients are MRD negative at a year at the lower level, and 65% of patients at the at the um at the deeper level at 10 to the minus 6. And when you compare that to the triplet, these patients are having better responses, more MRD negativity.
So I guess the new data was on, as we said, the sustained MRD negativity rate. So I understand that this was presented in this trial at the 1 in 100,000 level of resolution.
Yes. This is at the 10 to the minus 5 resolution level. And what we're seeing here is that not only are we able to achieve these very deep responses in MRD negativity at 12 months, but we're able to sustain those remission rates and those very deep responses. And so this is again at 12 months and at 24 months, and you can see that patients continue to benefit from the use of the quad in terms of their depth of response over time.
And were there any pointers towards who was going to have sustained MRD negativity versus not?
So I think this is where the crux of myeloma therapy is really going these days. And it's that we can achieve these deep responses. And for some patients, we can get these sustained responses, but there are still a subset of patients who don't have the same level of benefit, both from MRD negativity and in achieving that MRD negativity. And this data also supports that idea, and that patients who have standard risk or do not have high risk cytogenetic abnormalities, people with lower stage disease, are those people who are achieving greater and longer rates of MRD negativity. So it to me suggests that we still have work to do, particularly in those high risk patients.
And what about the subset analysis? Were there any pointers in here?
I think that for me, this subset analysis really is just dramatic in how well all subgroups benefit from the quad induction regimen versus the triplet regimen. And so across all these subsets, we're seeing that pretty much everyone is seeing benefit from the use of the quad. And that's something that we haven't always been able to detect in all of our trials. And this is seen both at the 12-month mark and at the 24-month mark. So it really is benefiting across a large group of patients.
And has this translated into longer term outcome benefits?
And this, I think, is one of the slides, and it really helps support this idea and is part of why now we're focusing so much on MRD negativity, because it really does seem to be that achieving MRD negativity is what helps us predict who does better. And so the use of the quad helps us achieve MRD negativity at a deeper rate. But here on the left, you can see that it's really that MRD negativity, in whatever way you're able to achieve it, is what predicts for the longest progression-free survival. So these patients do incredibly well when they achieve MRD negativity. What remains for us to determine is who needs all this additional therapy to achieve MRD negativity, and who might we be able to de-escalate sooner or maybe not use all of the therapies and modulate better for toxicity. And that's something that we just don't have yet.
And I believe they even looked at a longer period of sustained MRD negativity in addition to 1 year, 2 years. And any comments on this analysis?
I think the most impressive thing here is the rate of sustained MRD negativity. So these patients who are achieving these MRD negative rates are really able to sustain this at such a and they're not relapsing. So these patients are doing incredibly well. And again, it's achieving the MRD negative status that matters. And 98% of patients at 2 years who are just so this is they had MRD negative for 2 years, but at 4 years, their PFS rates are 98%. We've just never seen anything like that before. And it really does favor the idea that sustained MRD negativity predicts a better outcome.
Another trial that was presented at the ASCO meeting was an analysis of the ISKIA study and how sustained MRD negativity was uh, predictive of outcomes. So, once again, can you tell us what this trial design was?
So this is another trial that looked at transplant-eligible newly diagnosed patients who were less than the age of 70. And patients were randomized to either a triplet induction now with the carfilzomib lenalidomide dexamethasone backbone, and then the investigational arm had isatuximab, which is another anti-CD38, added to that KRD backbone. And so this was also patients got their 4 cycles of induction. And one of the things I liked about this trial design is that they actually used the drugs in the way that we typically use them in the clinic. So the carfilzomib was dosed weekly, the dexamethasone was dosed weekly. It wasn't such high doses of dexamethasone. So I found this to be a pretty approachable trial and easier to extrapolate to some of our clinical practice because of the way they dosed it. These patients got their transplants after 4 cycles of induction. They got 4 cycles of what they called full dose consolidation. So that was just repeating the induction regimen after the transplant. And then they had a year of light consolidation. And this is more sort of what we often do in maintenance, which when the carfilzomib goes to every other week and the isatuximab in the investigational arm went to monthly, which I think was a nice addition for the data because that the monthly isatuximab is often more practical. So they got their 12 cycles of light consolidation, and then these patients were off therapy.
And what do we now know about the depth of response that was attained?
So again, we're seeing very high levels of response. The depth of response here is also just something that we really haven't seen before. And even though the KRD backbone did really well and had impressive rates of MRD negativity, the addition of the anti-CD38 still improved on these results. So again, just really high rates of MRD negativity. And you can see here, this even, looks at some of the deeper remission rates at 10 to the -6. And again, just very high rates of very deep responses.
Yeah, I think you brought this out already that they did, in addition to the 10 to -5, they looked at a 1 in a million cell depth and showed a better depth of response. So, what about with the light consolidation phase? How did things pan out?
So I think this is, one of the questions is, what we can do to improve upon if MRD is our goal, how best do we achieve that? And one of the things that we're seeing here is that the addition of the light consolidation, we're still seeing very deep responses, but not exactly huge conversion rates on those patients, 77 to 79% is not a huge difference versus the triplet backbone.
And when you analyze at a deeper response level of 10 to -6, does the analysis change in any way?
I think this is where it really starts to pick up some of the power of this particular study and this particular regimen. And this is where we're seeing that when we look at these very deep levels, which again is something that we didn't always have available to us, but when we look at these very deep remission levels, this is where we see the benefit of this ongoing therapy and the use of the quad versus the triplets and seeing these very deep remission rates.
And anything to comment upon the sustained MRD negativity and the subset analysis presented?
So, one of the things I liked about this trial was pulling out these, single high-risk cytogenetic abnormalities, the multiple high-risk cytogenetic abnormalities, because as I mentioned, these are the patients in whom we really have work to do. And so when we're able to see a benefit for a quad induction regimen, even in these very high-risk patient populations, I find that this data is powerful. And again, at just very deep levels.
And I guess this further speaks to what you were uh, saying a minute ago.
Yeah, exactly. I mean, here when you look at these multiple high-risk cytogenetic abnormality patients, and these again are the patients that we struggle the most to treat. And when you're seeing this level of difference, and remember that we have lots of data that says that these high-risk cytogenetic abnormality patients, they benefit from MRD negativity as well. It's just that it's either harder to achieve or harder to maintain. So being able to both achieve it and sustain it, even in this high risk setting, we know that that's important. We know that it's prognostic and it shows that we're moving the needle in a fundamental way.
So, do you, before we wrap up, check MRD negativity in your patients? And do you use MRD in any way to for decision making? And how, if any, will this set of data change your practice going forth?
So I have been using MRD status to direct therapy. And I think that the field of myeloma has evolved so rapidly that traditionally I've been using it in the post-transplant setting to help us guide maintenance. How much consolidation do you need? If you're already MRD negative, do you have the same benefits to something like a consolidation strategy, particularly if we're looking at that 10 to the minus 6 level? So I've used it there for some time. One of the things that has changed is that with some of our newer therapies in the second line, patients are wondering, does everybody still need a transplant? And I find it can be informative in helping patients to assess how well they've responded to their induction therapy. I think one of the things that I'm not comfortable with and that I don't yet know or understand is what we do with this sustained MRD negativity rates over time. Does this mean that we can actually stop therapy if someone achieves some MRD negativity for some X amount of time? I don't feel that we have the data to say that there are patients that we can, yes, we can stop and you'll do just as well. And some of the longer term data from trials like the Perseus trial or there's a dramatic trial that will help us understand that better. But I still think that even in those high risk patient populations, that's still a patient population that sustained MRD negativity might mean something different for those patients in terms of stopping, and that maybe we can't stop in those patients because we know that those patients can still relapse quickly. So I think that it is a useful tool. I think it's becoming increasingly useful, and I think that it helps sustain the idea that that really should be our goal for most of our patients in trying to achieve that MRD negative status at the very deepest levels.
Well, I really want to thank you very much for sharing your views on this topic. And obviously, MRD is an area where we'll continue to get more data, and I hope that I can turn to you in the future to tell us more as the data evolves.
Absolutely. Thanks for having me. It's always fun to talk about the new and exciting and what's going on in myeloma.
Thank you very much.
Thank